I want to introduce our next speaker, Dr. Stephanie Evans. Stephanie Evans earned her Doctor of Physical Therapy degree from the University of Iowa in 2006. Throughout her career, she has specialized in the evaluation and treatment of neuromuscular or neurological conditions, in large hospital-based therapy clinics. In 2013, she joined the outpatient rehabilitation team at the University of Iowa, where she treats patients and collaborates in several multidisciplinary clinics. These clinics provide comprehensive services for individuals with Parkinson's, ALS, myotonic dystrophy, and other neuromuscular disorders. Additionally, Stephanie serves as an adjunct faculty member in the University of Iowa's Doctor of Physical Therapy program. Dr. Evans, thank you for being here today, and I will now turn the time over to you.
Thank you, Sarah. I'm really happy to be here. I'm going to go ahead and share my screen. And does that look okay?
Looks good.
All right. So, what we are going to focus on today is not only just physical therapy, but also activity and exercise considerations for those with myotonic dystrophy. I think some of what we are going to talk about is really going to complement some of the things that Dr. Batley talked about already. And these are going to be our main focus. I really want to just educate on the importance of overall physical activity, and not just for some of the things that we typically think of for exercise. So not just for weight management and strength and things like that, but also in managing other symptoms associated with myotonic dystrophy. I'm going to go through and discuss all the different types of exercise, and then really talk about how do you determine what you should do and is it safe. There are a lot of barriers to exercise. So for someone without a neuromuscular disease or other neurological disease, people those people really have a hard time maintaining exercise programs. I mean, I've gone through periods myself where it's really hard to stay on task. And so we're going to discuss those barriers that are common to everyone, but also unique to myotonic dystrophy, and talk about how to manage them. And then I did want to get into specifically some physical therapy, what that typically looks like, and maybe, if a person is at the point where they need assistive devices, adaptive equipment, we're going to go through and talk about some of those things and just the process of determining what's going to be most beneficial and how you go about it. So in general, this is why we should exercise. So we know that exercise reduces the risk of secondary complications like high blood pressure, heart disease, diabetes, obesity, osteoporosis, and even some types of cancers. And this is true for everyone. It's true for people with and without neuromuscular diseases. What's also true is it's good for your brain. So it's been studied for many, many years, the importance of exercise for brain health, just with aging in general, not even just for people with neurological disorders. And regular exercise has been shown to reduce the risk of cognitive decline and dementia. And so we know that some conditions will definitely put people at risk for cognitive changes, but we can also combat some of those other things that might not be associated with disease process. So I like to talk to my patients about what's good for the heart is good for the brain. I think in general, people know that they should exercise for heart health. I feel like that's been something that's been marketed for years, but brain health hasn't been mentioned as much. So I think that has been something that sticks with my patients when I say what's good for the heart is good for the brain. Exercise can improve your mood, reduce fatigue. In myotonic dystrophy, we've already talked about apathy, and so that can be something that's highly prevalent in this condition. And so getting on a regular exercise program can help combat apathy as well. It also can be a barrier, so we'll discuss that later. As Dr. Batley said, it can reduce pain. When we talk about that central sensitization. That's that chronic pain condition where we know that you can have changes in your brain that makes you more sensitive to those pain responses. And so there are techniques in physical therapy and just with regular exercise that can help reduce central pain symptoms. Also, you can address joint stiffness and things like that that can help reduce pain. So we'll go into that a little bit more later. A reduction of falls or reducing your risk of falls. So if we can maintain muscle strength and for as long as possible, that can help reduce the risk of falls. So let's say someone has decreased strength in their ankles, which puts them at risk for tripping. If we can do exercise, regular exercise to try to maintain some of that strength, it can maintain balance reactions a little bit longer and help people fall less. And then, just as I was talking about with the reduction of falls, is that ability to combat the muscle loss. So this Dr. Batley put this really, really well in her presentation, that it's really hard for us to know is atrophy of the muscle, so shrinking of the muscle, due to inactivity, or is it disease process? We know that if anyone is sedentary, doesn't move their body, is very, very inactive, they're going to have muscle loss because of that inactivity. We also know that neuromuscular disease can cause that. So we want to try to find a good balance with what people can tolerate, what is safe, so that they can combat that muscle loss for as long as possible. All right, so we're going to go into the specific types of exercise. I think sometimes this can get confusing and overwhelming for people. So we're going to go into each one of these. So the aerobic or cardiovascular conditioning, strength training, flexibility or range of motion, and then balance training. So aerobic exercise or cardiovascular exercise is continuous movement that elevates your heart rate, your breathing rate. And examples of these could be brisk walking, biking, swimming, dancing. So anything that can get your heart rate and your respiratory rate elevated and keep it there for a period of time. So when you see recommendations for exercise, these recommendations are from the American College of Sports Medicine, and this is the same for people with and without neuromuscular diseases. It is recommended 30 minutes a day, 5 days a week of moderate intensity exercise. So one of the things I like to emphasize with this is I put in there the 150 total minutes a week, because the cumulative effect counts. So a lot of my patients will say, there's no way I can get on the bike and go for 30 minutes at a time. So we try to find a strategy to get that cumulative effect of your 150 minutes a week so you could make it more doable. And it might be that you can't start with that moderate intensity exercise and you have to start a little bit lighter and build up. So how do you determine intensity? Some of the things that are commonly used for someone to just do some self-assessment for intensity would be RPE scale, a talk test, or monitoring heart rate. So RPE stands for rating of perceived exertion. So with my patients, there's several scales that exist, but for my patients, I tend to give them a 0 to 10 scale. And I say, okay, 0 is you're sitting, you're completely at rest. 10 would be you feel like you're exercising at your max. If we are looking at that moderate intensity exercise, we want you to try to make it to a 5. So that's going to be 5, 6, somewhere in that range is going to be that moderate intensity exercise that we want to shoot for having your 150 minutes a week in there. And if we can't get to that 5 or 6, we might just need to add some minutes or work our way up to it. And so when we look at that 5 to 6, sometimes I'll say, okay, another way to look at this is doing the talk test. So if you're exercising at moderate intensity, you should be able to hold a conversation, but you can recognize that you're breathing a little bit heavier, and it would be really hard to sing. So that's kind of a little trick that we'll use for people to determine, am I in a moderate intensity stage? And then heart rate. So we can calculate your heart rate range by an estimation. And I feel like this is tough for people to do at home because you need a good heart rate monitor, something that's going to be accurate. And when you calculate it, you have to calculate your max heart rate and then take a percentage of that. So for people who might be exercisers already, this might be right up their alley. I have some people who are very regimented. They've been exercisers their whole life. They want to monitor their heart rate response and get a good heart rate monitor and do this. For most of the people I see, I tend to not go this route. I even know for myself, I don't feel motivated to monitor heart rate and get into a certain range. So I'll use the other scales when I do exercise. All right. So strength training. So strengthening is the training that you use to improve either muscle strength or muscle endurance. You use repeated contractions against resistance with things like weights, elastic bands, resistance from water, so doing water exercises, or even moving your body against gravity. I think an exercise I tend to give almost every patient that I see are sit to stands from a chair because you're moving your body weight against gravity. It's a squat, so you're activating a lot of different muscle groups, and it's something that everybody can do. They might need to have adaptations like increasing a chair height or using their arms, but it's something that most of my patients can do, and it's a really effective exercise. The the main question I get is, can it hurt me? So I've been a therapist for over 17 years, and I think even earlier in my career, people were much more conservative, and I think there was lack of research with exercise, specifically strengthening for people with neurological disorders in general. And it was, you always leaned on being more conservative. You don't want to overdo. So you underprescribe exercise, and things have really shifted over the years. So they've actually studied exercise with neuromuscular diseases, and everyone's a little bit different, but and we do have a few disorders that we are a little bit more cautious with strengthening exercises. But with myotonic dystrophy, moderate intensity exercise has been shown to be safe. We do want people to self-monitor though. So your history of exercise does matter. Like I said before, if someone is an exerciser and has been, they might know that they can kind of push things a little bit more and their body tolerates it fine. If you are new to exercise, I definitely have been, what I want to say, I have done this in the past to myself, been guilty of this is the words I was looking for, where I started a new exercise program, personal trainer. I had never really strengthened before. This was, early on in my college years. And I pushed myself to the point where the next day I had trouble kind of reaching up and washing my hair. My arms were just so sore, so tired. We know that we do not want to push that hard for people with neuromuscular diseases. So if it is something where you do an exercise and you, within maybe a couple hours after exercise, you still feel so fatigued that it's affecting your function. You're having trouble getting up from a chair, whereas normally you wouldn't. Or like my example, I had trouble washing my hair. We've had people who will get to dinner time and they've pushed their arms so much that they have trouble bringing their fork to their mouth. We definitely don't want people to do that. Okay. And most of my patients learn this the hard way, that it's a little trial and error, and you shouldn't be afraid of an exercise program because of this. It's just that you want to start slow and give yourself time to work up and monitor your response. The analogy that I'll use with people is you have your gas tank for the day. So when we're talking about fatigue, your gas tank might deplete a little bit quicker than it used to, and it might take a little bit more time to fill up, but that's your gas tank. When it's done, it's done. So you want to go into it, especially if it's a new program, slowly and assess your response and then increase over time. We tell people that we want to have them avoid pushing their muscles to a lot of muscle pain. So this is sometimes counterintuitive for people who are used to strength training without a neuromuscular disorder, because in those cases, we are pushing the muscles until you feel that burn. We want to break things down so that the muscles can build back up. And we know that we want to be a little bit more cautious with that with neuromuscular disorders. So in general, we don't want you to push into a lot of pain and cramping. And we do avoid resisted exercises for muscles that already have profound weakness. So if someone has, lost their ability to completely raise their arm up over their head, not due to stiffness or pain, but due to weakness around the shoulder joint, then that is not something where we're going to have somebody take a weight or an elastic band and try to push through it. So we I'll talk a little bit about this later, but we do always encourage range of motion, and that would be a good case for that, but we wouldn't do strengthening with resistance with that. Um, and then also allowing time for recovery. So when you look at recommendations and research for strengthening activities, you can get the benefits of in maintenance or get stronger doing an exercise program with strength training 2 times a week. So when I was talking about the aerobic exercise, that one, we want you to have several days a week. If you're going to do that 30-minute chunk, it's 5 days a week. With strength training, you can get by with less. You could add it in a couple days a week and still get really good benefits. I liked this chart because I think it gives a little bit more information about where we want you to have you in that moderate activity zone. So, or intensity zone, I should say. So if you are doing lifting for muscle power and strength, a lot of times we're getting that resistance up quite a bit higher. And those are what we want to avoid with strengthening with myotonic dystrophy. We would rather it be in that moderate level where you can do 8 to 12 repetitions of an exercise and feel like you can accomplish it. It might feel a little bit hard towards the end of those repetitions, but it should be doable. And then again, you do your program and assess your response, and that's where you're going to alter it from there. I also think that if someone can't get into the moderate intensity where they're doing 8 to 12 repetitions with maybe a moderate weight, bringing it down into that light resistance category is still okay. Even moving against gravity, that example that I gave with the shoulder, we might be giving active range of motion to try to maintain the muscle strength, and that might require a little bit more repetition. All right, so next category of exercise is strengthening or range of motion. So stretching or range of motion. So when we're looking at stretching, it's lengthening or elongating a muscle to the point where you are going to get changes at the muscle level or the tendon, which is the part that attaches the muscle to the bone. Typically, with a stretching program, especially one that you're performing, with 30-second holds, you're doing a couple of repetitions, we can improve that extensibility of the muscle, which in turn can make a joint move better. So earlier, pain was talked about. And so if a muscle has, if a joint has weakness in the muscles around it, and stiffness in the muscles around it, that joint is not going to move quite as well as it should. So I think about like a ball and socket joint. If I have, and the shoulder's a good example again, if I have that joint and I have weakness, um, it's not going to keep that joint in the best position to allow me to have full pain-free range of motion. So then over time, you're going to get stiffness as well, which is then really going to make the joint not move the way that it should. And so I think sometimes people think, oh, I can do these stretches, once a week or once every few weeks, and it'll be fine. But being consistent with stretching can really help with pain complaints. So, going into our guidelines, we want you to be moving into that feeling of stretch. Sometimes it's a hard thing for people to know what it feels like, but it shouldn't feel sharp. It shouldn't feel like you have a lot of apprehension, but just a stretch sensation. And then you're going to hold that, like I said before, 30 seconds or even a little bit longer is fine. And do that for 2 to 3 repetitions. That's what's shown to help improve and elongate muscle length. Um, some of the adaptations that our patients that we see in the clinic might need is someone else might need to help them. Like if it's something where someone's hips are pretty weak, but we need a really effective ankle or hamstring stretch, something like that, we might have to have a care partner assist. We might also consider a position change. So if I am not able to raise my arms up overhead when I'm in a seated or a standing position, sometimes lying down and using gravity to assist me will be a better idea. And then in other cases, we might need to consider bracing for more prolonged stretches. So I wanted to give a few examples of this. Um, these first, I don't know if you can see my cursor here, but the first boot looking thing is something that we will use if someone has ankle weakness to where they have a complete foot drop. So um, the muscles that pull the ankle up, the ankle and the toes up, are weak to the point where they just can't move that joint anymore. We worry about then the muscle behind the ankle, the Achilles tendon and the calf becoming contracted, making the toes point in a downward position. Even for people who are no longer walking, and maybe they just are standing for transfers, we don't want that contracture to happen because then it makes standing harder. Even people who are in a wheelchair, it can make positioning their feet on their foot pedals harder. So this is kind of used in more cases where people have profound weakness and then they're at risk for contracture. I included some of the hand ones that we tend to use a little bit more. This is definitely not my area of expertise. We have very skilled occupational therapists that work with us, and these tend to be the most common splints that they give. So this one's a thumb spica splint. This might be one that can help improve joint pain, like if you get joint pain in your thumb. It might also just help with positioning the hand for better use of it, functional use of it. This one down here is called a wrist cock-up splint. What that one does is it can help maintain your wrist joint in a slightly, well, stable, slightly extended position, which in turn can help the hand function and grip a little bit better. And then these oval 8 finger splints are quite common too for people who might have some either excessive movement or excessive tightness in their finger joints. And they can just do that prolonged positioning so that we're getting a prolonged stretch or we're preventing contracture. Okay, balance is the last category that I put for exercise. And when we think about what makes good balance, we have three systems that have to work together for having good balance. One of those is that sensory system, our ability for the feet to feel when we're off balance, send the signal up to our nervous system and back down to make the muscles work. to help keep our balance. So if you think about like standing a heel to toe position, like that tightrope walking, um, all those little wiggles of our feet, those are what's supposed to happen. Those are our balance reactions. Our muscles are working to help keep us in that upright position. We also have our inner ear balance center. So it's called our vestibular system, that inner ear system that helps us orient and keep our balance, and then our vision. So I think if you think about that heel to toe standing position, we want those balance reactions to be quick and effective. So you have the little wiggles in your ankle, and if that's not enough, we'll throw our arms out and our hip strategy kicks in. And when that's not enough, we have a stepping strategy that catches us. So when we work with people in the clinic on their balance, that's what we're focusing on. We want to keep those reactions quick and adequate so that if you are off balance, you're good at catching yourself. Some of the things that can make balance more impaired are, I think one of the biggies that we've already talked about is that ankle weakness. Those are the muscles that are supposed to kick in for your ankle strategy. So if they're profoundly weak, then your balance reactions are not going to be quite as good, and we need to think of other solutions. Joint stiffness, limitations in your range of motion because of that stiffness, those can all impact balance and contribute to falls. So a lot of my patients will say, okay, are we actually going to be able to get this better? And we have been able to show them through research and just our clinical experience that yes, balance can improve. If we challenge it, we can help upregulate some of your systems, especially that inner ear balance center. I think as people get less active, that system is less challenged. So we call it like a hypofunction. It just doesn't work as well. And so we'll do things like incorporate balance with head turns, or we'll have people close their eyes so their vestibular system and their sensory system have to work harder with the lack of that third input that helps with our balance. Okay, I hope I'm not talking too fast, but this all leads up to, so what type of exercise is the best? It's a lot to have to think about having to do all four categories of exercise. How am I going to get this done? What's the best? And ultimately, find something you enjoy. So your consistency is going to be what's the best, and you're not going to want to be or the consistency is what's going to make the most impact. And if you don't enjoy what you're doing, then you're likely not going to stick with it. So we're going to talk a little bit more about that in this barriers category. But I think when you meeting with a physical therapist can really help to hone in on what you need, and then they can help you be creative in finding ways to accomplish that. Some of this, I think I talked about already, that light to moderate exercise, including that resistive training, has been shown to be safe for people with myotonic dystrophy, as was discussed earlier. We do have to keep in mind that there are cardiovascular considerations. So people should be meeting regularly with their cardiologist before starting a new exercise program. It should be discussed with your doctor. Your neurologist is a good resource as a starting point, and they might set you up with a physical therapist who can do some additional or initial testing with you to see what your heart rate response is, and monitor things as you progress. And then, as I said earlier, your previous exercise history does matter as well. Stretching, range of motion are always okay and encouraged. So I alluded to before that we really want people to maintain range of motion around a joint, even if the muscles are weak, because that can help with your pain control and pain management. And then balance training, that's another thing that as long as the setup is appropriate, you might need guidance on how to do that. I think balance training should be done every day. I tend to have people do it in a corner. So they're standing in a corner with walls on each side. So you're close to the wall, but not touching, and then have a chair in front of them so that you're kind of surrounded. You can reach out and touch the walls if needed, and then we start in a way that is safe for the person. Um, I do think having a physical therapist train you on some of those balance exercises first is likely a good idea, just to make sure that you're not putting yourself at risk for a fall. All right. So the motivation can be really, really, really tough, not just for people with myotonic dystrophy, for everybody, but that consistency with exercise or activity is the key. So we want you to have it regular and ongoing. So we discussed making it enjoyable. I think having small goals to start is a really, really good plan. Um, it's been shown that people that schedule in their exercise and they keep track of it are more consistent over time with their exercise programs. So having an exercise journal would be really good. I'm going to show some resources at the end of this presentation that you can even print out. It's a really nice exercise sheet that you can just check the boxes and keep track of things. Um, Participating with a partner or in a group exercise class can be really helpful just for that accountability aspect. Um, if you know that you've got this class and you've got people that you like to spend time with, you're going to be more likely to do it, or you're going to show up for your partner, meet them out for a walk or at the gym. And then now there's so much technology to help with consistency. I don't know about any of you, but I feel like I tend to look at my Apple Watch and I want to get my move goal for the day and my steps in for the day. And so that's something that can help keep people motivated. So it doesn't have to be an Apple Watch. There's all kinds of things like Fitbits and other companies that have those. There's even just pedometers that can do a step count for a day that are inexpensive. And then with technology as well, I think utilizing some of the online resources for adaptations. So I know MDA website has a whole list of things, or I think it was a blog post on the Quest magazine, that ways to adapt activity and ideas for exercise. And YouTube, I'm going to show you a resource at the end of this where they have a ton of different videos that are adaptations for exercise. So utilize that technology to help with your motivation and consistency. All right. So when we're thinking about when to see a PT or an OT, I think, go ahead here. If you're new to exercise, I think it's a good idea. If you're having trouble figuring out ways to adapt to meet where you are, I think it's a good idea. If you feel like you just need some help with that initial uh, determination of what you should be doing, or anything like that, I think it's a good idea. So what we do, at the place that I work, sometimes our patients are coming from 3 hours away or from a more rural place where they don't have a lot of access to those who are educated specifically with neurological disorders. And so sometimes we'll just do this initial visit or a one-time visit, or even the initial evaluation and a follow-up. And so we'll keep things kind of short and sweet, where you're not having to go to therapy 2 times a week for 6 weeks. I feel like that's sometimes something that people aren't aware of, that you have the ability to do that. Um, when you go for that first session, I really feel like your therapist should be asking you and focused on, what are your goals? And if I know someone's coming from far away, I try to minimize all of the testing. I might want, to do 8 different functional tests, but we might not have time. So what I'll do is do my testing to get an idea of where we start, and then we'll get right into what their goals are and trying to give stuff that day for home. During your testing, we have a group of measures that we use. So from a PT standpoint, we have a group of objective measures that we'll use for people with neurological disorders. Those typically include assessing stability walking, stability while you're standing still, looking at strength and range of motion, balance. Oh, I already mentioned balance, but walking speed is another big one. So these are tests that we can track over time. So there are some, if I know that I'm only going to see somebody for 1 to 2 visits, and then they're not going to come back for another 3 to 6 months, let's say. I still like to get these measures down because then we can track them over time and compare how someone's doing. You can tell a lot just by a simple walking speed test. And then as far as the evaluation goes too, I think if you are looking for a physical therapist, one thing to ask when you're making your appointment, if you're, especially if you're in a place and your doctor's not too sure, is asking if the therapist has experience working with people with neurological diseases. So I'm lucky. I work in a large institution where I get to specialize, and I only see people with neurological diseases. There might be some place that's smaller that they don't get as much, but I'd still pick the therapist that sees the most of it so that they are aware of your condition and know some of these guidelines to help you. And then when it comes down to treatment, like I said, it could be kind of send you off on your own after a visit or two, or you go to therapy for a while to address things that you want to address and what your therapist thinks is important. I think with me, in addition to the person's goals, I safety is kind of one of those big areas that I always kind of keep in the back of my head because it might be that offering something like a recommendation for an assistive device or a brace might help to improve safety, decrease risk for falls, that sort of thing. And then those goals that you have, of course, are going to change over time, especially if your function changes, your impairments change. And so I do think it's good to meet with a physical therapist, pretty regularly, meaning you could have a bout of therapy and then another check-in 6 months after. At least once a year, I think would be good to kind of check in. Sometimes we get to a point where care partner training is more of the emphasis. If somebody has impairments that cause them to need more assistance, it's training those care partners that's going to be the most important thing for that person and their family. All right. So we're going to talk a little bit about some adaptive equipment. And one of the things with um, exercising is people get concerned about their ability to grip hand weight or a bar when they go to the gym. So I wanted to make people aware that there are some adaptations out there that can help with this. One of the ones that we use are wrist weights. So these are actually adjustable weights that you can slide the little weight bars out of them to adjust how much weight is in each cuff. And so we might use those for things like raising up overhead, bicep curls, for someone who has a lot of hand weakness. Resistance bands. Sometimes it's a really simple fix where we'll tie the resistance band around the wrist or loop it around several times to give people that support that they need in order to have some resistance with bands. Grip assist gloves. So this one here, we have these in our clinic and they're a really great grip assist glove. So I have people who can use machines, even like those cable machines where you're pulling, against weight. If we put the grip assist gloves and we use, let's say the same handle, they can just rest with the gloves on and then go back to do their second set. And then this is a lifting hook. So these, they're more for exercises with dumbbells and certain exercises because they don't work with all of them. So I think someone with profound hand weakness, we tend to kind of go more towards the grip assist. All right. So, foot drop. Um, just to review, we've talked about this a few times, is when foot drop occurs when the muscles that pull the toes and the ankle up get weak to the point where the foot will either slap on the ground or someone has to use their hip to help pick the whole leg up to clear their foot when they're walking. Um, in addition to the muscles that pull the toes up, we also have the calf muscle that helps you push up onto your toes. Those muscles also can commonly get weak in myotonic dystrophy. So sometimes we will recommend either for safety or sometimes knee control or more efficiency with walking, we'll recommend an AFO, which is short for ankle foot orthosis. So in the years that I've been practicing, there's been so much advancement where now we have these carbon fiber braces. And my clients that feel these for the first time, they're so surprised how lightweight these are. And I think that's the key with the carbon fiber bracing is if someone has foot drop, but then we know they have hip weakness as well, we don't want a big, bulky, heavy brace weighing down the leg that causes their hip have to work harder to pick up their foot when they walk. Or, um, if you're looking at one like this down here, it's really hard for them to get on because of the strapping system or something like that. So with these braces, we have the ability to trial them in our clinic. We have fit kits, or you meet with an orthotist. So they're the orthotist prosthetists. They're the people that make the orthotics and prosthetics. And you'll go into their office and they will try the different brands on. So there's a ton of different brands now. There's different positions for the posts. So something like this comes up the back of the leg here, or you have one that are a type that has an anterior shin plate. And this brand or this style, I should say, can offer a little bit more knee control. So you would really want to discuss this with your therapist or the orthotist before you would just pick one and or buy one out of pocket. Insurance does cover these typically. So you would need an order from your doctor, and then the orthotist will submit it. I don't think any of our orthotist office even charge for the office visits. They're billing for the orthotics. And then down here, I included, this is a more custom brace. So these can now be made out of carbon fiber material, but also there's like a plastic type of material that historically that's all we had as options. These braces still are indicated for some people. So depending on the amount of weakness, or if someone has an ankle that tends to want to roll out, like it's going to twist or sprain, we might have to jump to something more custom like this. And so with this process, you have a cast made around your foot and your leg to then have it be formed, the material they use to form a brace that is the most supportive for you. All right, so mobility devices, I'm going to focus on canes and walkers here. One of the biggest questions that I get from people is, what about a quad cane? So the second cane here is called a quad cane, and they make them with small bases or quite large bases. And typically, the quad canes are better for people who have to walk very slowly. So I typically will have people feel this in the clinic if they're set on a quad cane, because if you don't have all four of those feet down at once, it can feel pretty wobbly when you use it, and people don't really like that sensation. So if you are someone who walks faster, pretty continuous, a single point cane might be the route to go. Um, these are three different styles of walkers. So this one here is a front-wheeled walker, and these can be good for people. They sometimes don't move outdoors very well, or for people who might have a faster walking speed. So trialing it with your therapist is probably a good idea. And then you have two different styles of rollator walkers here. The difference is this one, the red one, folds so that it's a little bit more compact. And then this one here folds inward kind of this way. That's hard for me to explain, but people will sometimes have a preference with how they fold to get it in and out of their car or the weight of the walker. So again, this is something that you can discuss. I do like the idea of having a seat. So we talked about fatigue earlier, and just for energy conservation, fatigue management, having a seat to be able to always have a place to rest is a good idea for a lot of our patients. All right. So this is another big question we get from clients is, well, what about a scooter? Can I use a scooter for longer distances? And then we'll start the conversation of what's the difference between a scooter and a power wheelchair? And how does this work with insurance? So I wanted to kind of go over each one here. So this is a mobility scooter. This one here is a manual wheelchair that's a very basic manual chair. The one down here is a group 2 power wheelchair. And then the green one down here on the bottom is called a group 3 power wheelchair. So the thing about insurance is they only like to, and I'm going to kind of use this as a generalization because there are exceptions, but they only like to pay for one wheelchair in 5 years. And so when we're looking at making recommendations for this, we really have to take into consideration, do we have patients spend or use insurance benefits for something like a mobility scooter if we know that they might need something a little bit more within the next year or two, and will we get that justified? So um, the scooters tend to be the quite a bit more inexpensive compared to the power wheelchairs. So if we think that this might be an option down the road, we'll recommend those. I'm going to go into the wheelchair evaluation process because this is such a confusing and frustrating process for people. So as I said, insurance likes to pay for one wheelchair in 5 years. And in order to get a wheelchair covered, we have to be able to show that the client needs it for in-home use. So unfortunately, the story we hear from a lot of people is, I'm doing okay walking in the house, but I have trouble, in the community going out of my house. And I really want a power chair for that. And that is what insurance does not like to pay for, unfortunately. So we have to show that maybe the efficiency or safety in the house isn't where it should be, and that can help us get wheelchairs justified. Um, the doctor's order has to be in, and the wheelchair company, the vendor that orders the chair, will work with the physician to get the right paperwork in. And they need to have a face-to-face appointment with the person and to discuss the needs for the wheelchair and, talk about falls or gait instability, that sort of thing. And so that's an important part of this whole process, along with doing this evaluation with someone who's knowledgeable, a PT or an OT that really knows how to do these, because the paperwork process is quite extensive and you don't want denials. We want to try to avoid denials so that the process doesn't take longer than it should. I think if anybody has any questions about that, I'd be happy to answer specific questions later. All right. So I alluded to some of the resources. I found some really good articles under Quest Media on the MDA.org website. Those have specific things, not even just with exercise and therapies, but also nutrition. So I'd encourage people to look at that when they're considering just improving their overall activity level. Also myotonic.org. Lots of great resources. I did want to point out that this guide is on the myotonic.org website. And it is a really nicely laid out comprehensive guide for exercise for people with myotonic dystrophy. And if you look at the last pages, those are some of those resources I talked about with the YouTube videos. And I mean, it goes from balance, yoga, chair exercises. There's so many different things on there. It also had that exercise log that you could print out from this guide and use it just to help keep you on track. A lot of the points that I made in this presentation are included in this guide. So I think this is a very well done resource for people with myotonic dystrophy. All right. So I think we'll have Sarah open this up for questions.
Yes, thank you so much for that informative presentation. All right, yeah, we will jump right into some questions here. Like I said, some were submitted upon registration and some are submitted in our chat box. So feel free to continue to put questions and we'll try to get through as many as we can. So our first question here, are there any resources for transitioning into a wheelchair, such as counseling?
Um, Absolutely. So I do I mean, I'm very, very lucky to have a team where I am, where we have a rehab counselor on staff. So she is fantastic just with knowing about chronic neurological cases and helping people with those strategies for transitioning and coping. Also, CBT was mentioned earlier, so that cognitive behavioral therapy can be a really helpful strategy for people. I do think that if you have a physical or an occupational therapist that are knowledgeable in this area, they've been working with specifically neuromuscular disease, um, talking things through with that therapist and going over, potential barriers and benefits. I think there's a lot of things that our patients and care partners don't really consider with how much a wheelchair can improve independence. And if you get the right functions in a wheelchair in particular, how much of a difference that can make for people in their house and their caregivers. I think a lot of our patients are worried about being a burden and asking too much of their families. And so improving safety and independence can really help with that.
That's a great point. And I also want to thank Sean, who linked that exercise guide in the chat. So if anyone wants
Oh,
to take a look at that, I was also looking, but I didn't find it in time. So thank you so much, Sean, for that.
thank you.
Um, all right. So do you know if Medicare covers PT for myotonic dystrophy?
Absolutely. So with Medicare, I think we always, kind of think about Medicare being so restrictive, but with our patients, we actually don't have a visit limit. So some private company or private insurances, they'll say, okay, you have 20 PT or OT sessions for the year, and some of them have a hard stop. Some of them, the therapist has to submit progress notes to get additional visits covered. Whereas Medicare, we are required to do our initial evaluation, and then a doctor will co-sign our plan of care. And then every 10 visits, we do a progress note so that we're retesting, we're updating, and we're addressing goals. And so there are some clinics, I'm lucky because I'm in a hospital-based system where we don't have a really super hard cap for Medicare patients. I can see them for quite some time. I think the model that we try, over the years that I've been a therapist, we have been trying to do for people with chronic neurological cases is um, have a check-in like you do with your dentist. So we're used to going in every 6 months for our checkup and our cleaning. And so a lot of my patients will use that. We'll start our course of therapy, and It might be that they want to come for just a few visits and get started on an exercise program. It might be that we work on balance training for 4 weeks. Then we discharge. Hopefully, people will have their exercise program in place to perform on their own. Then we do another checkup in 6 months, and those are absolutely indicated and not restricted through Medicare. The other thing that is one of my biggest pet peeves is I've had people say, well, they had to discharge me because I wasn't making improvements. And for the majority of the people that I treat people that have conditions that over time are going to get worse. That does not mean that therapy is not indicated. I don't have to show consistent progress to keep someone coming to therapy. I have to show that I am providing a skilled service, that I'm addressing goals or monitoring and adjusting goals to meet needs. And those are what matter for Medicare to keep paying for therapy. That was kind of a long-winded response, but I'm very adamant that when I hear somebody say, "Oh, they discharged me because I wasn't making progress after 1 month," that's not realistic or necessary to have Medicare keep covering PT or OT services.
Great, thank you. And I think sometimes when it comes to insurance, there is no shortcut to the answer. So thank you for all that information. Um, I have I have DM2 and have difficulty getting out of a chair. I use a booster seat for restaurants, which tend to have armless chairs. Is there hope that I can, with the right exercise, improve to no longer need the booster seat or be able to get out of lower chairs? Or can I just hope to slow further progression?
I think that is a case that's hard to answer specifically. Just with regards of what I said during my presentation, it's hard to know what is disease process and what is disuse atrophy. So maybe something else has led to decreased activity over time. And so the muscles have started to become weak just from disuse, not necessarily from disease process. So in a case like that, if I were to see somebody in the clinic, I would definitely have people work on it and we'd adapt it to make it work for them. So, one of the things that I'll do, just like you're already doing, is raising your seat heights up. And then I'll have people work on repeated sit to stands. And we might have people lower slowly to make the muscles have to work a little bit harder. And if that's tolerated, we can progress from there. Um, I I don't know if it's something that someone is pretty convinced that it's disease process, then doing the activity absolutely can help maintain where you are to prevent a faster decline with further worsening of that ability to get up from a chair. So I think regardless, and I hope my presentation helped solidify working on it is a really, really good idea, regardless of those two cases.
Yeah, absolutely. We have time for a couple more questions. So, someone asked, can the AFO exacerbate or cause the patient to develop hip pain?
I think an altered walking pattern in general can lead to people having hip pain. So sometimes I see the flip side of that, where when we get somebody in AFO, their hip isn't working as hard to help clear the foot, so then the pain goes away. So I think on a case by case basis, that needs to be looked at. I do think that if the AFO is causing the walking, which this can happen sometimes, especially with hip weakness, the walking to be a little bit harder or the AFO is too heavy, there are cases that it can make hip pain exacerbated. So that is a perfect thing to have a therapist take a look at.
Good point. So, kind of similar to that question, I tend to easily sprain my knees easier now. Can AFOs help with wobbly or weak knees?
They can. If you are providing support at the ankle, because of that lower leg position, you can actually help with some knee stability. Now, sometimes if people are super strong on their ankles, I definitely don't jump to bracing their ankles just for knee support. We might look at other options for the knee. Um, Even like a neoprene type of knee brace can offer just some of that input and support that'll be enough for somebody. So it kind of depends on your strength, both at the knee and the ankle, to determine if we would use the AFO versus considering some other type of bracing.
That makes sense. Thank you. And then we'll do one more final question. So, how can a person with a level 3 chair use a computer without being stretched out across the desk?
Oh, that is, yeah, that can be tough. I for most of our patients, and our OTs help with this a little bit more than I do, but I think having an altered desk is sometimes the best route. So um, that we can get the height high enough above the armrest to bring it closer. So some of our patients will use like a rolling type of bedside table as a desk, or adjustable height desk. Um, Obviously, if you're not flipping out your joystick, getting that out of the way can help you get a little bit closer. Um, those are kind of the quick things right off the top of my head, I think, that we tend to go for.
Perfect. Well, just to be respectful of your time, I want to wrap it up, but thank you so much for all of your expertise and for all you do for the community. This year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum toward transformative progress for people living with neuromuscular disorders. To learn more, visit mda75.org. We again would like to thank Dr. Batley and Dr. Evans for sharing their time and expertise with us today. We do want to hear from you. Let us know, what did you like about today's program and what can we do differently in the future? Please fill out the brief survey that will pop up right after this webinar. Your feedback is important to us. If you have any questions or are looking for support or resources, please contact MDA's Resource Center at 1-833-275-6321 or via email at resourcecenter@mdausa.org. I again want to thank our program supporter, Vertex Pharmaceuticals, for supporting this virtual learning series. Last but not least, we again invite you to join the MDA community. Joining is free and will help you stay up to date on our programs as well as on the latest research. Please scan the QR code with your smartphone or visit the link in the chat. If anyone has any questions after this webinar, please feel free to contact MDA's Resource Center by phone or email. The information was placed into the chat, and they will be sure to get back to you. Thank you again to our speakers for your time, and thank you to everyone who attended. This does conclude today's webinar, and we hope to see you again soon. Thank you.